Okay, well, we're really pleased to be here with Dr. Micichael Peluso, presenting with us for the second time on one of our webinars as expert bridging HIV, COVID, and long COVID. He is the Assistant Professor of Medicine in the Division of HIV, Infectious Diseases, and Global Medicine at UCSF. He's also an infectious disease physician and HIV primary care provider at San Francisco General Hospital. For the last 5 years, his primary areas of focus have been on chronic sequelae of HIV infections and efforts towards an HIV cure. When the COVID-19 pandemic began, he implemented the UCSF long-term impact of infection with novel coronavirus study, which is LINC, the LINC study, one of the first COVID recovery studies in the country. It investigates the clinical and immunological consequences of COVID, including long COVID. He's also co-investigator on a national study of COVID recovery in people with HIV funded by AMFAR. Dr. Peluso also serves as co-investigator in the newly launched NIH Recover Consortium, for which UCSF is one of the institutions enrolling nationally. Thank you, Dr. Peluso. We appreciate you being here. Also, as someone who is on call and on service this week and a parent of a baby. So we really value your time and appreciate your work. Turn over to you.
Okay, JD?
Yes.
Okay, great. Hey, everybody. Really happy to be here. I'm Michael. I'm a light-skinned person, short dark hair. I'm in my office at San Francisco General Hospital. Occasionally my Wi-Fi cuts out. So if that does happen, I will rejoin in 30 seconds, I promise. And I think that you are all seeing the correct screen. So I will proceed. So like JD mentioned, I'm going to spend most of the time that I have tonight talking in my first presentation about long COVID, and then I have sort of a brief overview of where things are at with what is now known in California as Mpox, kind of officially. And happy to take questions at the end. I am a New Yorker, so sometimes I talk too fast. And if I'm doing that, please slow me down. So I'll begin by talking about where things are at. In September 2022 with long COVID, and in particular, some recent results on long COVID in people living with HIV. And as JD mentioned, I've been involved in post-COVID work, both clinical work and research work for 2.5 years now, which is crazy to think how much time has passed. And most of this has been in a program called LINC, which follows people after they have COVID. And we've been, following some volunteers in our research program for over 2 years now. And then more recently, I've been involved with the large NIH program called Recover, which you may have talked about, that has many of the same goals as our local program, which is understanding the long-term post-infectious consequences of COVID. So, as you all surely know, everybody on the planet has been affected in some way by COVID, either through getting the infection themselves or knowing somebody who has. And fortunately, most people who get COVID fully recover after their infection, but not all do, and some have prolonged issues. This is referred to as long COVID. Some people with long COVID refer to themselves as long haulers, but not everybody. And what this really means is the physical and or mental health symptoms that don't go away in people who've had COVID. This can happen in anybody. It can happen in young people, old people, hospitalized people, people who are at home, and it can even happen in people who were vaccinated to protect against COVID or people who receive COVID treatment. There are a lot of technical names for the condition. The NIH refers to the condition as post-acute sequelae of COVID, or PASC. The CDC now refers to the condition as post-COVID condition, which was an interesting choice. Most people experiencing these issues refer to it as long COVID. So I started seeing people experiencing long COVID way back in May of 2020 before it even had a name. These are some people from our research program or who I care for clinically, who I've gotten to know quite well over the years, and I think demonstrates what people are dealing with. So I'll just briefly review some of these stories. A 43-year-old computer engineer whose primary manifestation of both acute COVID and long COVID has been dysautonomia, or sort of wild swings in her blood pressure and heart rate that causes her to fall really frequently. A 65-year-old nurse who's a person living with HIV who got COVID and experienced really severe brain fog. He was afraid to return to work because he was so worried about making a medical error. A 33-year-old reporter who had previously won a bunch of awards for her writing, who ended up actually losing her job because she was no longer able to meet deadlines due to difficulties with concentration and ability to write. A 40-year-old transgender man who was on stable testosterone therapy for a decade before he had COVID, and then subsequently developed really debilitating post-COVID headaches that resulted in his provider having to wean his hormone therapy. It's obviously quite problematic. A 35-year-old marathon runner who now is unable to walk or run a couple of blocks. And these were all people who were considered to have mild COVID, according to the clinical definition. I think all of them would say that this has really had a severe impact over the long term on their lives. So I think the important thing to understand is that now long COVID is really well described. We know what it looks like in all sorts of people, how it can differ between people, and that it has a big impact on people. And even a year ago, there was a lot more controversy around this. I think that fortunately over time, this has become a more clinically recognized condition. This slide lists some of the symptoms that some people might experience. These include neurologic symptoms like headaches or trouble concentrating, cardiopulmonary symptoms like heart palpitations, chest pain, issues in blood pressure, like I mentioned, gastrointestinal symptoms like nausea, diarrhea, changes in weight. But there are all sorts of symptoms. And the important thing to know is that the symptoms differ between people. They can differ over time within a person and kind of come and go. And they can have an impact on quality of life. And in some people, that might be a mild impact. And in some people, it can be quite severe. I think this was best summarized by a researcher in St. Louis who basically said that if you've seen one case of long COVID, you've seen one case of long COVID. It really, everybody has their own story. So I'm going to talk a little bit about where we're at in terms of understanding why this might happen, and then what the efforts are to figure out how to potentially treat this, with the caveat that there are still more unknowns than there are knowns at this point. So this slide is from a paper I wrote a few months ago, sort of summarizing our opinions about this. But an individual who survives the acute phase of COVID can either go on to fully recover, or they can experience post-COVID issues like long COVID. There are a number of demographic or clinical characteristics that we know may make somebody more likely to experience long COVID. This includes female sex, middle age, so not necessarily the extremes of age, not very, very young or very, very elderly people, but kind of the bulk of people. People with pre-existing medical conditions, particularly diabetes and obesity. There was a lot of talk at the beginning of the pandemic by people who were skeptical of long COVID, who would say, oh, well, this really just affects people who are really well off and kind of have the opportunity to feel unwell. That is not borne out at all in my experience or in the data. And unfortunately, I think that there are multiple studies now in the US and internationally suggesting that people with lower socioeconomic status, fewer resources, and less access to health might be disproportionately affected by long COVID. And then I'll show you some data that is concerning to me about HIV as a risk factor for long COVID. So those are all clinical characteristics, but that doesn't explain why this actually happens in people. So I'm just going to spend a few minutes and talk through where we're at in terms of understanding what is the biology that might be driving this. And if people have questions about more details of any of these things, I have some extra slides that we can talk about in the Q&A. But I've listed here sort of the main areas of investigation right now. So at the beginning of the pandemic, as an HIV clinician and researcher, people would ask me, what is the difference between HIV and SARS-CoV-2? And I would say to them that the difference is that HIV persists in a person's body after they get the infection, but SARS-CoV-2 comes and goes. And that was what we thought 2 years ago, but there is a growing body of evidence now that suggests that at least pieces of the COVID virus may stick around in the bodies of people who've had the infection. And I think that this evidence is becoming really hard to ignore. It's still not a slam dunk certain thing, but this is a major area of investigation now. So there are multiple studies by our group and other groups suggesting that you can measure persistent pieces of the virus in the blood or in the tissues for months after a person has had the initial infection. And so that is thought to potentially be a contributor to long COVID. There's also a lot of interest in inflammation in a person's body, either systemic inflammation, inflammation in the blood, in total body, or localized inflammation in specific tissues like the heart or the brain or the lungs or the GI tract. There are multiple studies now that have shown higher levels of inflammation in people experiencing long COVID. These are not through the roof levels that you would necessarily measure on a test if you went to your doctor, but you can kind of distinguish people with and without long COVID based on these levels. And so a major area of focus now is what is actually driving that inflammation. Is it the potentially persistent virus that I just talked about? And are there anti-inflammatory treatments that we might be able to use to get people feeling better? The third area that's being investigated is the reactivation of other viruses. And so there are lots of other viruses that we all kind of get over the course of our lifetimes. The most notorious one is the Epstein-Barr virus, EBV, which is the virus that causes mono. Basically, like 95% of adults get that virus at some point in their lives by the time they reach adulthood, even if they've never had like the syndrome of mono. And so there's some evidence from our study and from other studies suggesting that early when somebody has COVID, the monovirus may reactivate, and there's a question about whether that is driving some of these symptoms. Fourth is the changes that happen in our bodies after we have COVID related to all of the other organisms that are sort of a part of us. So like a huge proportion of our total body mass is actually made up by all these other bacteria and other viruses that kind of are just there and have roles that we don't really understand. Some groups think that changes in the microbiome, all those good bacteria that live in our body, might contribute to long COVID symptoms. The fifth area is clotting issues. There's a lot of attention on this recently. We know that acute COVID causes lots of clotting issues in people who are sick in the first few weeks, including, unfortunately, some people who get really bad blood clots. There's a group in South Africa that really thinks that issues relating to blood clotting on sort of a microscopic level could be contributing to long COVID symptoms. And so that's being investigated. And then the last point here is every immune response that we have to an infection involves the good, productive immune response that's doing what it's supposed to do, and all of the other immune chaos that happens, sometimes which can be misdirected against ourselves. And so some people think that that an imbalance between a productive immune response and a non-productive immune response, including autoimmune responses, immune responses against our own bodies, can be causing long COVID symptoms. So these are the main areas of investigation right now that people are trying to figure out. I'm not going to go into a ton of detail, but this slide is basically to demonstrate that for each of these potential causes of long COVID, there are now efforts to mobilize clinical trials to see if intervening on these potential causes can affect how people feel. And so my hope, although I've been saying this for 18 months, is that these studies will launch and enroll and actually lead to some real answers on how to get people feeling better and really understanding which of the mechanisms I just discussed are actually driving the disease. So I'm now going to transition in the last couple of minutes, talk about HIV and long COVID and some things that I think are concerning. The first thing I think is concerning is that there's actually very little known about HIV and long COVID, and there are very few studies on this topic, which is kind of surprising to me. The first signal about issues with HIV and long COVID came from this paper that was published about a year ago and actually had nothing to do with HIV. It was an analysis of people who showed up at the emergency room in New York at Cornell early in the pandemic and just what happened to them a year later. And these were people who didn't get admitted to the hospital, but showed up to the emergency room. And what they found was that the small number of people with HIV in that study were more likely to have long COVID at 1 year than everybody else in the study. So they were about 75% more likely to have long COVID. So that's interesting, but small sample, not really focused on HIV. We recently completed a study in our cohort in San Francisco where we looked at 40 people in our study with HIV, and we matched them to 40 people who were similar age, sex, gender, whether they were hospitalized during acute COVID, to see whether the people with HIV looked different in terms of their immune response or in terms of long COVID. And what we actually found was that the same types of people, same measurements, people with HIV were 4 times as likely to report long COVID at 4 months compared to people who were HIV negative. That was very surprising to me. We have a lot of people with long COVID in our study. And it's, I think it's quite concerning. It's not, again, this is not the definitive study to answer this question, but I think it suggests that, at least for me as an HIV provider, I need to be really mindful of this in my patients who've had COVID, which frankly at this point is the majority of my patients who've at some point had COVID. We recently did another analysis in our study kind of a year later, looking at the relationship between different factors and specific types of long COVID symptoms. And it seems like a lot of the increased reporting of long COVID in our participants who are living with HIV and have had COVID are really driven by fatigue and in particular neurocognitive symptoms after they've had COVID. And so being HIV positive was a strong predictor in our study of reporting post-COVID neurocognitive symptoms that did not exist before people had COVID. And so that's also quite concerning to me, and we're trying to figure that out. So why might a person with HIV be at higher risk for developing long COVID? I mean, these are some thoughts. I don't have any answers. We know that in all comers with COVID, people who are living with HIV tend to be at least slightly sicker during the acute infection. And we know that the severity of the initial infection can drive long COVID. So maybe it has to do with that. I personally don't think that that's the explanation, but some people might say that. We know that people living with HIV are more likely to have other medical problems. And we know that medical comorbidities are something that drives long COVID. So perhaps it's related to that. We know that even people with HIV who are on long-term antiretroviral meds are suppressed, undetectable. They do still have slightly higher levels of inflammation, and maybe post-COVID inflammation layered on top of HIV-associated inflammation can drive long COVID symptoms. Similarly, we know that people with HIV have subtle chronic immune dysregulation that can potentially be compounded by COVID. And so, and there are a few more things here, but ultimately, like, these are all hypothetical, and now I'm spending a lot of time trying to figure this out. And so I hope that we'll be able to have some answers soon, but right now there are still more questions than answers. And then just to wrap up, what is long COVID treatment? Long COVID treatment is highly personalized, and right now is almost exclusively focused on symptom management rather than getting to whatever the root cause of the problem is, because we still don't have a definitive answer on what that might be. What I tell people is that you really need to have a provider who you trust and who can advocate for you and can listen to you and who can support you, even if they don't have a lot therapeutically to offer right now. There are long COVID clinics and long COVID centers of excellence that are popping up. A lot of these lean heavily on rehabilitation and physical therapy. This is not right for everybody, particularly people with long COVID that has a lot of sort of post-exertional malaise type symptoms that can be worsened. So, really anything like this needs to be done with clinical supervision. I actually think that support networks like this and groups on social media are really important because so much of long COVID management right now is hearing people out and making them feel connected so that when things become available, people know what to access, how to access them. And so I think that those groups do a lot of good. And as I mentioned, most studies right now are focused on symptom management, but not addressing the underlying pathology. And this is because we need still more advocacy around therapeutics, particularly for investment in therapeutics on the part of the NIH and willingness to provide therapeutics on the part of companies that have medications that could potentially benefit people with long COVID. The best thing that a person right now who does not already have long COVID can do to prevent long COVID is to get vaccinated. There are multiple studies from multiple parts of the world showing that pre-vaccination to protect against COVID reduces the likelihood of developing long COVID with a new COVID infection. That being said, the effect size varies. It is as small as 15% reduction to as high as like 60% reduction, but all of these studies show benefit. The new boosters, the bivalent boosters, are available now. The difference between these shots and the older shots, that the old shots were developed against the original strain. The new boosters have both the original strain and BA4, BA5. I will disclose that I actually was a participant in the clinical trials for the boosters because I believe in them so strongly. And so I actually got a combined booster as part of a study back in April. And I'm going to get another one tomorrow. And yeah, some people say there's no safety studies. There are definitely safety studies because I was in one. What there is not is a lot of efficacy data because the studies have been relatively small. And so most of the efficacy data is showing that these elicited good broad immune responses, but we will see this winter what the efficacy is. So just to wrap up in the last 30 seconds, I think that these are the key questions that I have is like, what is the mechanism of long COVID? And specifically, is there ongoing virus? Because that is a problem that can be intervened upon. As now we enter this new phase where people are getting reinfected. I saw somebody yesterday who is after their third COVID infection. Is this going to increase or decrease the likelihood of long COVID? You can make arguments either way. Are we satisfied with symptom management, which I'm not sure we're doing a great job of right now, or are we really trying to reverse the pathology? How do we actually measure this in studies? There's a lot of resistance on the part of study funders and regulatory agencies to accept what I think are actually the most useful endpoints, which are how people feel. But everybody really wants there to be something you can measure in blood, and we don't have that. And then how do we convince everybody who needs to be on board to get clinical trials going and to develop treatments for this on board to do that? Because we're 2.5 years in and not as much progress as I would have liked has been made. Just to give a plug to the study that was mentioned before, Annie Antar, who's investigator at Johns Hopkins, has been working over the last year to actually answer specific questions related to long COVID and HIV. JD and Gabriel and Jen and others in this group have helped advise us on this study. The study is enrolling through the end of September. So if anybody you know has recently had COVID, or if you happen to be unlucky and get an infection in the next couple of weeks, please consider participating in this. We're still looking to enroll people living with HIV who get COVID. And we're looking to actually extend the study after the end of the first phase this fall. This last slide has a few more helpful resources that I won't talk through, but I think are sometimes useful and can be shared. And I will end there on this topic and turn it back over to JD.
Great, thank you so much. So now's the time when we could do some Q&A with Dr. Peluso. We have one question that's come in, which is how long should people wait after the second Mpox vaccine to get the new booster, the new COVID booster?
Yeah, that's a great question. You know, the pharmacies say 4 weeks to space out. I'm actually not sure what data that is based on, but I think that that is a safe amount of time. I would not do them closer than 2 weeks. So I basically been telling my patients 4 weeks.
Great. Okay. Any other questions for Dr. Peluso? Also know that you can keep adding questions along the way, even if we're onto the other segments, and we will chase Dr. Peluso down to get answers and send them out with our proceedings from the webinar and the materials. Okay, I think that that's it for now. Thank you so much for your presentation.